decisions. Some officers and partners may be joining the meeting via Microsoft Teams. Are any members in attendance as substitutes today?
Sorry, is it back?
That one. Yeah, I'm here for Dr. Colin Hicks, who's on leave. So I'm Izzy Davis Fernandez, Managing Director for Brighton Hove from Sussex Partnership NHS Foundation Trust.
Good afternoon, David Kemp on behalf of Hannah Yalden, Free Sussex Fire and Rescue Service.
Do any members wish to declare any interest in relation to any matters included on the agenda? We have no part 2 items today, so the press and public won't be excluded. Does the board agree to approve the minutes of the meeting on the 8th April 2025 as a correct record? In June, I had the pleasure of opening the Health and Wellbeing Board partnership event discussing results of the 2024 Health Council survey hosted by the University of Brighton. This research gives us some of the best evidence of the health and well-being of our population, as well as inequalities across the city and those faced by particular communities. This research was only possible because of the collaborative approach across the council, NHS, the universities, primary care, health watch, and the community and voluntary sector, reflecting the strong partnership approach of our Health and Wellbeing Board. This event saw partners from across the city discussing what we can do differently as a system to tackle the inequalities evidenced in the research. There's an update on today's agenda on the survey findings, the themes that came out of these discussions, and the next steps in working together to tackle inequalities. With regards Health Watch, as the chair of the Health and Wellbeing Board, I want to express my support for our Health and Watch Brighton and Hove colleagues following the announcement in the NHS 10-year plan that the work of local health bodies relating to health care will be brought together with integrated care board and provider engagement functions, and that local authorities will take up local health watch social care functions. Since their inception in 2012, Health Watch Brighton and Hove has been an independent voice for people living in the city, gathering patient feedback to understand the lived experiences of people who use health and social care services, and use this to influence debate around local service delivery. We need to ensure that this vital work is not lost with these changes. Finally, I've been asked to take the item on the drugs and alcohol strategy earlier in the agenda to allow some presenters to attend who would otherwise have had a meeting clash. This item will consequently be taken immediately following the SAB annual report. I would like to call I'd like to ask the members of Democratic Services to call the items out.
Thank you. So I'll read out the items on today's agenda. If members could indicate if they wish to debate those items. Item number 6, Safeguarding Adults Annual Report. Item 7, Brighton and Hove Pharmaceutical Needs Assessment. Item 8, NHS Reform. Item 9, Director of Public Health Annual Report. Item 10, Health Counts, Publication, Health and Wellbeing Board Partnership Event and Next Steps. Item 11, Reducing Harms from Drugs and Alcohol. And item 12, Better Care Fund End of Year Report. I can confirm that all items have been called.
Thank you. We have no public questions today. And no member questions either. So we'll continue with the first item. That's so I would like to invite Katie Harker, consultant in public health. Yes. Did I confuse him? Yes, that should be that. Okay, sorry. We are going to do item number 6 on Safeguarding Adults Annual Report, and I would like to invite Shiona Douglas, the independent SAB chair, to introduce this item.
Yeah. Can you hear me now? Always good to check. Thank you, Chair. It's a pleasure to be here. I'm the independent chair of the Safeguarding Adults Board, so it's really good to be here this afternoon to deliver the annual report to the Health and Wellbeing Board. I guess it's just to kind of, one of the things that is really important is that I'll talk through some of the structure around the report and then some of the content and highlight some of the ports. And then obviously, if there are questions, quite happy to answer that. And if there are questions we can't answer, hopefully Guy might be able to help me, who's the board manager, or we will take the question away and find out from partners, because sometimes you just never know what's going to be asked, but we will try and do our best in terms of answering anything that comes up. So this is the annual Safeguarding Adults report, and I guess that in introducing it, one of the first things I really want to say, this is about the people of Brighton and Hove, and about how partners work at a strategic level to support the operational services, to protect people from risk and to prevent people from harm. And I always think it's always important in these documents to think about we're talking about the people of the city here. And so this is our annual report. And just to kind of set a little bit of background around the Safeguarding Adults Board, which was established at the time of the Care Act, which seems a long time ago, 2014. And it's about every partner, multi-agency, working together to provide leadership and strategic oversight of the adult safeguarding work across the city, across Brighton and Hove. And that involves a number of partners which are listed in the report. At the end, you will see that on page, I think it is 32, I'll come to it, is there's a list of the partners who attend the board. But I can summarise that they are from a cross-section of the statutory partners, that's social care, the council, healthcare and the police, a number of voluntary partners, And in particular, Chair, you've already highlighted Health Watch, who have been a significant contributor to the Safeguarding Adults Board. And as the independent chair, I would like to express my sadness at the proposals for Health Watch, because certainly in Brighton and Hove, Health Watch have contributed significantly to the board and in about listening and helping us with the voices of people. And that's been one of the major pieces of work we're trying to engage with, is to hear from people about their safeguarding experiences, so that as a partnership we can consider those and ensure that we're meeting those needs, and where things don't work out so well, we're hearing those voices from them. So I just think it's really important to acknowledge the work of Health Watch, and also just want to acknowledge the work of partners and of the board office of Guy Jackson and his team, who have contributed and keep the smooth oils of the Safeguarding Board running at meetings and throughout the year. So thanking them. There are three statutory duties of a Safeguarding Adults Board, and that is to develop and publish a strategic plan which sets out the strategic objectives for that partnership and how those will be met. It's to publish an annual report detailing the activities that have been undertaken during the year and the effectiveness of those, and to also arrange Safeguarding Adults reviews to be undertaken when the criteria is met for those reviews, which is generally when unfortunately somebody has died or there has been a very serious incident where somebody has suffered a significant harm, who has care and support needs, where the agencies perhaps have not been seen as working together effectively. And the purpose of those reviews is for learning. It's about improving practice across all the partners. And I'll come to highlighting that a little bit more. So in terms of our strategic aims, we've got 4 strategic aims, which are detailed on page 6, which is accountability, leadership, performance and quality, promotion and engagement, and integration and workforce development. And there are strategic aims, and each year we will look at a range of information, which is data from partners. We will look at audits or work that's been undertaken around practice, and we will look at the Safeguarding Adults Reviews learning, and we will set the priorities for that year based on that evidence. And in the year that we're reporting, which is the last financial year, we had 4 areas that we were looking at during the period, which was embedding learning from the Safeguarding Adult Board's activities, transitional safeguarding, developing effective outcomes to self-neglect, and embedding learning from trauma-informed and multiple compound needs. Now, the work of the board takes place through the partnership, and my role is to lead that work, but to seek assurance as an independent person that those safeguarding duties are being met within those organisations. And so partners, it's not my board, it's the partners board. I'm always clear that it's their board, and that we challenge each other, and I will scrutinise and challenge also, but that we work really effectively as a partnership in an open and transparent way around challenging practice and improving practice, because that's what we want to do, is prevent and improve as a continual process. If I just turn to the pages which are from page 7 to page 8, you will see that this delivers for you, against the priorities, the work of the board over this year and the work that's been undertaken, the increasing awareness of safeguarding with professionals, the creation of high-level data in order that we understand what's happening and we can take action, and also looking at experiences and impacts from people in order to plan for the future. And it's really pleasing this year that on page 9, 10 and 11, we have some feedback from people who've used the services. And we know this is incremental work, and we're going to be doing a significant piece of work next year in terms of hearing people's voices more lively. So we will be commissioning some discrete work to support the board in hearing a wider range of people's voices around safeguarding. It isn't an easy topic to gain feedback from, because people are generally in distress, and it's not a time where people want to talk to us about their feedback. We do get feedback, but we want it to be much more informed in order to do that. So we're looking to develop that. But it is really pleasing to sit before you today, because last year I was talking about we will be looking at that, in that we do have some feedback through this report. So just to kind of flag that for you. The next section refers to our safeguarding adult reviews, and this is where the board is charged with the responsibilities to carry out safeguarding adult reviews in their area when somebody dies or experiences significant harm. When it's suspected that that harm or that death was caused as a result of abuse or neglect. And that includes also self-neglect, and also a concern that the organisations have worked together in a partnership way to ensure that. And you will note that we published one case review this year, which is detailed in the summary here. And there has been a lot of learning from that, and a lot of work has been undertaken since that review was produced. And it involved, very sadly, a young man who was in temporary accommodation and was suffering with substance misuse, and had been suffering abuse, and had been involved in criminal activity in his life as a result of the trauma that he suffered. And I think it's really important to flag that housing and homelessness has come into the Safeguarding Adults Board, particularly street homelessness, in terms of being something that the Safeguarding Adult Board looks at. That was directed by government over a year ago. But it's also incorporated the wider issues of housing and of cost boundary allocation. So when the city placed people out of borough, there's been significant work as a result of that to try and maintain people within the city so that they've got access to the services that they're in common with. And certainly, since this review, that we were hearing some significant work's being done. So it's still a struggle. It's not easy to house people within the borough, as you'll understand that you'll know that from yourselves, that there are challenges, but there is work underway, and the Safeguarding Adults Board is monitoring that work in the light of the improvements that were recommended through this particular review. The back of the report is provided by all of the partners who contribute to the annual review, reporting on their safeguarding activity in the year. I won't talk through all of that because it's quite lengthy, and I'll assume that members have had the opportunity to look through that. But we do require partners to contribute to the annual report, and that's their way of how they've translated what's happened into the board, into their organisations and into their practice. And I think at this point it's probably appropriate that I leave it open for questions.
Thank you, Sharon, for your report. And do we have any comments or questions? Okay, Caroline.
Thank you. Yeah, it's the first time I've seen one of these reports. It's a really interesting read, and safeguarding is a large part of what the organisation I do deals with on a daily basis. But the first thing I just want to say, where it's mentioned about the rapid response service, which has been launched, and we have used that on a number of occasions, and I've understood that it was extremely good and very welcome at the time. The other thing, I think it's on page 16 on one of the graphs. I was just, it was, oh gosh, I've whizzed right past it now. It was, the question was about the number of 16 to 24-year-olds. Seems incredibly low. I think it's page 16 or 17. Yeah, just let me find it. Sorry, holding everybody up. Yeah, page 33 of the big document, I think page 16 of the slides. And it was where the number of safeguarding reports is divided into age bands. And so the 18 to 24-year-olds seems incredibly low. And I just wondered why that might be. And I spoke to one of our team. We're wondering about maybe there's a bit of a gap in when people leave children, young people services and move into adult services. And so maybe they're being missed somehow, unless I'm misreading it.
Would you like me to answer that question?
Didn't get the question.
24-year-olds reported is so low.
Yes, please.
Can you hear me now? Yes, sorry. I can't answer the question here. I'll certainly go away and look at it. However, what I would say to you is there's been a lot of work undertaken around that transitional period, because that's been one of the priorities. And I know that children's services have been working with adult services in terms of a whole strategy for exactly that reason, in terms of ensuring that there isn't a lower number. But we need to go away and just kind of come back with a more solid answer for you, because it might be just quite helpful to check that out with partners before I give you something which may be inaccurate. If you're happy for me to do that, I can provide a written response.
Are you coming? Okay. Can we have Stephen, please?
Thank you, Chair. I'm Alan Boyd from Health Watch Brighton Hove. I just want to start by thanking the Chair and showing for your comments. They're greatly appreciated at a difficult time for us. And also just to say here, the changes to Health Watch aren't going to be happening anytime soon. They need a change of law, which means that our services will continue. We will continue to provide everything that we do now for the foreseeable future. So I just wanted to offer that reassurance. In terms of our role on the SAB, we're very proud partners, and Health Watch, Bridget Day, our Health Watch representative, chairs the SAR. And I think this year is really important for the board to know how much has been strengthened on the board, including our membership, the development of a multi-agency risk management system framework, and also a new dashboard showing data which allows us to look at metrics. And I think those are all really important developments. I think the focus on the transitions for young people is critical, especially if we look at the health counts data and the incidences of children experiencing, young people experiencing care and the health inequalities they're facing. So I think that's the right approach for the board. And I'm really keen to work with the SAB on trying to capture the user voice more. And that's something I think we can bring our independent functions of the service to help with that insight. So I just wanted to commend the report and also the leadership of the SAB, both with Shona and Guy, because I think it's gone from strength to strength.
Thank you. Any more questions? So yes, please, Steve.
Thank you very much. Alan, you've stolen my thunder because I was going to say something very similar, but I do think the Safeguarding Adults Board is a really good example of partnership working across the system. And Shona, thank you for your leadership in this. I know it's a partnership, but I think your role in this is really crucial. I think the report is really clear. It's not an easy read. And I think actually I encourage us to look at the case study. I know there's one in this one, sometimes there's more than one, because that really brings it home, just the challenges that we're dealing with. And so thank you for including that. I suppose on a similar vein, in my paper on NHS reform, one of the proposals is that integrated care boards will also transfer out their responsibility for safeguarding. But that will not happen immediately, partly because it's not yet clear where we would transfer that responsibility to. So until the law is changed, we will continue to be a good partner in whatever form that we can. And I just wanted to provide that reassurance too. But thank you for all that you're doing.
Thank you, sir. Any more comments, questions? This was.
Thank you, Chair, and thank you for the report. On page 20, I believe it's the second to last paragraph, I was just struck that we've got named GPs for safeguarding and they're offering separate advice line for GP practices. I know data wasn't included in this particular report. Are there any early indications of what that data will represent going forward?
Thanks for the question. And what I suppose what I want to say is it's been really good. We have really good engagement from the lead GP on the Safeguarding Adults Board, which isn't always the case throughout the country. So I think we're in a really good position. We don't have the answer to your question at this stage. I think it's too early to show, but it is an indication of the importance that GPs have placed on safeguarding. And I think it sets the city in a really good place. And we've got really good commitment from Sophie Calland, who is always present and takes things back. So I think, in terms of that engagement, I'm confident and assured that we're getting the messages to GP, which isn't the case everywhere. So too early to say yet, but I think what we need to do is, in light of your comment, is pick that up for next year's annual report to specifically bring that back, because I think it's a really important issue where primary care is alongside acute medicine and the other health services. So thanks for that question.
Any more questions, comments? Okay. Thank you, Shona, for the report and for answering the questions. The report recommendations are that the board notes the report and commends partner agencies for their contribution to safeguarding adults with care and support needs, and notes that Safeguarding Adult Board achieves achievements and challenges. Does the board agree? The next item on the agenda is reducing harms from drugs and alcohol strategy. This has been moved. I would like to invite Caroline Bass to present the report, please.
Thank you, Chair. I'm just going to introduce the report and then I'm going to hand over to my colleagues because this is a genuinely collaborative approach. So I'm just going to share my screen and then I will also okay, or maybe not. Okay, I'm just trying to get on full slides. There we are, lovely. Thank you very much. So the first thing I just want to say is that the artwork in the Reducing Harms from Drugs and Alcohol strategy and in the slide set here was all provided by Cascade Creative Recovery, which is a lived experience recovery organisation that supports people in recovery in our city. So I'm presenting the Drugs and Alcohol strategy, Reducing Harms from Drugs and Alcohol strategy, to the Health and Wellbeing Board. And the board is asked to note the strategy and to support the approach that the strategy is best delivered in partnership with the Combating Drugs Partnership Board, and that the Combating Drugs Partnership retains oversight to the implementation and monitoring of the strategy. So I'm just going to give you a very brief introduction, background, a look at the governance and the scope of the strategy. And then what I'll be doing is introducing the workstream leads who will take you through the 3 priority areas that we've identified in the strategy. So the Reducing Harm from Drugs and Alcohol strategy, it's a strategy that was developed in collaboration with all partners in the Combating Drugs Partnership, plus extensive consultation with people with lived experience of harms of drugs and alcohol use. We also received feedback from communities who are also sometimes on the receiving end of harms from drug and alcohol use in the form of antisocial behaviour. The Combating Drugs Partnership is a collaboration of multiple agencies that all have kind of skin in the game with regards to drugs and alcohol. So the police, community safety teams, treatment and recovery services, the NHS, children's services, and service providers. So we all came together in a Combating Drugs Partnership Board to start the process of developing a strategy to reduce harms. So the draft strategy has been presented at a number of fora since June 2024. It went to the People and Overview Scrutiny Committee, Brighton and Hove Health and Care Partnership, and multiple other stakeholder forums. And at the end of 24, we went out for public consultation via the Council's Your Voice portal, and then our partners on the partnership board also undertook consultation with their colleagues. So the strategy covers everybody who lives in, works in, or visits the city. It includes drugs. It also includes alcohol, but the alcohol element is more limited in scope. So what we haven't done is undertaken an approach to licensing with alcohol, but we have looked at alcohol harms, harm reduction from alcohol, and how treatment services providers can support people experiencing harms from alcohol. So the aim of the strategy was to recognise the complexity of substance use and all those risk factors that contribute to harmful substance use, such as untreated mental health conditions, pain, chronic pain, homelessness, experience of trauma. And one of the things that we added to the strategy was the experience, people who are care experienced, and also we strengthened the strategy with regards to the risk factors associated with neurodivergence. So those were 2 particular elements that came back in our consultation. So we particularly wanted to recognise those. So the Combating Drugs Partnership, and I've got this slide in really so that you can see how the Combating Drugs Partnership is set up and how the priorities that are identified in the strategy form 3 work streams that feed into the Combating Drugs Partnership. And those 3 work streams are the priorities within the strategy. So we've got the breaking the drug supply chain. So that will be the enforcement kind of element, the police, community safety. They lead that work stream. They would be here today. Unfortunately, again, this meeting clashed with the meeting of the chair of that work stream. So I'll just be presenting his slide for that section. Then we've got the treatment and recovery element. So this is about how we deliver a world-class treatment service that has the capability and capacity to meet our complex presentations. And then we've got a demand work stream. So the third aim of the strategy is to achieve a generational shift in the demand for drugs and alcohol. And I will let my colleagues tell you a bit more about those work streams. So I'm just going to summarise the priority one, disrupting the local drug supply chain. So this priority is developed by Workstream 1, and they will have actions that sit under these objectives, and we'll be monitoring those through the Combating Drugs Partnership throughout the next 5 years. So that priority, disrupting the local drug supply chain. So the aims are to disrupt the flow of drugs into the city, to provide a safeguarding service to prevent children, young people and vulnerable adults from becoming involved with those organised crime groups. And so the sort of actions that sit under that priority are things like breaking county lines, where we see them engaging with children's services to support children in a safe way to come out of that exploitation scenario. So working towards a thriving nighttime economy. We have a great, exciting nighttime economy in Brighton and Hove. We need to make that safe for people as well. And so that's where we work with the police in that. And then we have that other side of things about increasing the support to communities and how we work with communities who are experiencing drug-related and alcohol-related crime and antisocial behaviour. And then it's about improving those pathways between the criminal justice system and treatment services. And we've got sort of actions under those objectives that have, like, we call it diversion. So instead of arresting people, instead of charging people, they will be arrested and then diverted into treatment services should they need to. So that's just a very quick summary of priority one. And I'm going to come out of my loudspeaker microphone and over to you, and I will pass on. You just tell me what you want me to. Oh.
Thank you, Caroline. Just to introduce ourselves, my name's Ian Dunster. I'm the Director of Change, Grow, Live services for the region.
And I'm Fran Piccoletti. I'm the Drug and Alcohol Program Manager for Public Health.
Do you want to go?
Yeah, we are co-chairs of Pillar 2, which, as you see, have the focus on improving the quality, capacity, and outcomes for people in drug and alcohol treatment, and also provide recovery support.
In terms of what we want to do, on a really high level, we want to increase the numbers of people in treatment, expand the capacity of the treatment service to hold those extra numbers, increase the capability and skill mix of professionals, and improve integration between services and provide pathways into treatment for people with co-occurring needs. And they're very mapped to what Caroline was previously mentioning around the National Drug Strategy From Harm to Hope. The objectives that sit under that, I'll try and bring to life shortly a little bit. So increasing access to structured treatment for people with drug and alcohol need. So that could be anything from kind of raising the profile of our services to make sure that people are aware, working with GPs to make sure that there's kind of a one-click referral directly into our services, or kind of making sure that our services are very much out and about around the city so people know we exist and there are clear ways to engage with us. In terms of improving the capability of the services to support clients with multiple compound needs, within our service structures, we are making sure that our staff are appropriately trained, whether that's in trauma-informed care or various other approaches, but also making sure that we're linked in with the relevant multiple compound need boards and partnerships and part of those networks where those people are discussed and supported. In terms of improving the access and experience for services, young people and adults, I've talked a little bit about adults, but my colleague Adam will talk more about those young people and children. And there's a strong focus on harm reduction provision for people experiencing drug and alcohol. So we know that not everybody wants to stop using drugs. So we want to do everything we can to reduce the potential harm to them or others. And do you want to take over to talk about the last two? I realise I've dominated. Okay. So, and we obviously know that co-occurring substance and other needs are very prevalent amongst our group. So making sure that we have clear pathways, protocols, and agreements with our colleagues in mental health, particularly important, and there's some really good progressive work happening there. And in terms of drugs, we know that drugs and drug use is changing, so we are making sure that we are very linked in with our colleagues in the police that have been mentioned in the previous slides, but also our coroners and our local hospitals to make sure that we have a good local intelligence network which we've developed, and there's clear information coming into the service which allows us to work together to ensure that we are fit to support and aware of the changing needs, which are very much happening at the moment. Thank you.
Happy?
Oh.
Thank you. Thank you, Chair. Thank you, Board. My name's Adam Muirhead. I'm Director of Youth Work at a local charity called the Trust for Developing Communities, and an elected rep, voluntary sector rep in the Community Work Reps programme. And so I have been I'm co-chairing this work stream with Tanya Riedel, who is a manager of the adolescent services in the council's adolescent service team in the Family, Children and Wellbeing Directorate. But Tanya can't be here today, so you're stuck with me. I'm really pleased to be here representing the community and voluntary sector in this partnership. I think there's a huge amount that we can bring to bear with a kind of multi-sector lens on our priority in particular, which is about achieving a generational shift in demand for drugs and alcohol. So as you can see, our overarching aims are up there on the board. What we're particularly excited to bring to our part of the new strategy is the way that we'd like to work, which is in a human learning system. And we've agreed that this particular priority might require like a much longer term perspective, and a human learning system might be the way for us to generate the change that we need in the system in the city. So the first part of a human learning system is about really valuing those human experiences and understanding that these aren't just statistics, these are human stories, these are citizens of Brighton and Hove that we are talking about, and making sure that those voices, particularly of children and young people, come through in the work that we're doing and inform the work that we're doing really congruently. The learning part of a human learning system is ensuring that we are constantly finding the learning and promoting the learning. So that could be horizon scanning for best practice around the country and making sure we're bringing that here. That could be understanding the experience that people who use drugs or have used drugs and alcohol might have to bring to bear on our system. And it's also a human learning system is about the system. So we are looking for those strategic policy levers that we can pull to make this generational shift in demand for drugs and alcohol. So we're very excited for it all, and very much looking forward to getting stuck in on the new strategy and coming back and telling you in the future about all the wonderful things we've achieved.
Thank you very much for your report. Any questions, comments? Yes, Steve.
Well, first of all, thank you very much for the strategy and very supportive of the ambitions. I suppose I'm thinking about how can we make it go faster, because you're talking of a very long-term issue here, and you're talking of the complexity of working across agencies. And so I'm interested, what are the barriers to integration, and what could we do to speed things up?
Thank you. I'm going to take that question then, I think. You're right, this is a long-term situation, it's a long-term issue, and we've seen some of the conditions that have promoted poorer health from drug use get worse and worse. So we are in a privileged position. Over the last 3 years, we've received additional supplementary funding to support the programme around drugs and alcohol, and that's been very much focused on treatment capacity, and our treatment capacity has increased significantly. we'll start to see the significant impact of that going forward. We understand that the funding is going to be delivered in a slightly different way going forward, although the details are not entirely clear at the moment. But that will help us potentially take a broader look at how we deliver this strategy. I suppose there's something about partners actively engaging to help really progress this. I was going to say at pace. It's not something that works at pace. It's a steady burn, and our main, the main aim is to ensure that we have a society and a city that's free from those harms, and that takes time, and we will put that time in, and it is about putting the time in across all partners. It is an interesting situation when you're working with different partners, as you say. So the police have very different drivers than say public health do, but we are working very closely with them, and they are committed to this strategy. So that's in fact everybody involved is really committed to it. So that's really fantastic. I suppose one of the other challenges is the change of personnel. So we're continuing to update and discuss some of those issues and that where that organisational memory has gone, which is it was ever thus, and that's what we will do. But I think having this strategy published now, or accepted, or noted, approved by the Health and Wellbeing Board, is a real provides us with that impetus to take it forward through the Combating Drugs Partnership in a really strong way, and to use that funding in the best possible way to deliver this.
Thank you. Any more questions? Yes.
Thank you, Chair. Thank you for the presentation. I think the strategy is really needed at a point in time, especially the health counts data showing that 20% of adults have tried drugs not prescribed for them in the last 12 months, which is of the 16,000 people who completed the survey, that's over 3,000. If you extrapolate that, it's going to be a lot higher. I suppose my question was around the groups that you've had limited engagement with and how you're hoping to engage with them going forward, because I note that the Health Count survey points out that people who are more likely to have tried drugs include those aged 18 to 44 and people from multiple ethnic groups and younger people and people from Black and racially minority groups are groups you haven't heard from as much. So I'm keen to know how you're hoping to engage with them going forward. And I suppose I was wondering whether the school's wellbeing survey, I can't remember what it asks, but does that provide an opportunity to plug some of our gaps? There are so many questions in there, I can't remember which ones they ask. And obviously, this isn't something we can do by ourselves. Drugs crosses boundaries. So I was just interested in what partnerships we have in the wider region and beyond the regions.
Thank you. I'll start off with the response and then I'll hand over to my colleagues. We were really, really disappointed that we didn't get more engagement with people from Black and racially minority groups. We did actively try to do that, but I will hand over to Ian and Fran at some point because we're doing additional work on that. With children and young people, we're taking a completely integrated approach with, and Adam is helping take that forward. With regards to the boundary work, you're absolutely right. And some of our partners actually have that Sussex-wide approach. So the Police and Crime Commissioner, the police service as well. And we have close engagement with our East and West local authorities around drugs. You know, when we're looking at county lines, there's no border issue, you know. What's happening in Hastings is happening here. So we absolutely need to have that engagement and oversight. And we're lucky that CGL have fingers in multiple pies in that route. But I'll hand over to the co-chairs to talk about the engagement work that's happening because they're closer to it than I am.
Thank you for the question, because I'm really passionate about engagement with ethnic minority, being one myself. It's true, we struggled with engagement when we started with this with a consultation for the drug and alcohol strategy. So we started consultation a year ago. So we took the learning of the difficulties of the engagement and introduced culturally competent workers inside CGL, Oasis, and now we are working on this also for Are You OK, our children and young people service. When we started this work, I have to report our engagement was really low. We had maybe 2 or 3% of people accessing service that were coming from Black and ethnic minority. Now I can report from the last quarter of 24-25, our demographic is really similar to the one on Brighton and Hove. So we're engaging with around 23-25% of Black and ethnic minority in our service, in our mainstream service. We have a dedicated worker, we have a dedicated space. We translate our work, we translate our flyers in multiple languages. We are able to have translation service when we cannot deliver in another language. We have access to a translator service via phone or in person. How is best for the person that access, and we really focus on a person-centered approach. It's complicated and is a lot of more resources will be needed because we do have a really interesting demographic in Brighton and Hove, and this is one of the reasons why I moved here. But as you know, approaching a multi-ethnicity is always come from challenges and barriers. What I will have answered to the question about how can we support this work. We need cultural change across organization to work on supporting a drug and alcohol strategy that's really work on aligning strategy and delivering in the territory. But thank you so much for the question. I don't know if double act.
I don't have anything to add in terms of the cultural diversity. I think Caroline touched on it. We are lucky that CGL, in a sense, have services across Sussex, and there's a good level of learning that's shared. And obviously there are colleagues such as SPFT and different areas different organisations that oversee that large area. So we're lucky we have good strategic links across Sussex, whether it's police, probation, mental health, and hospitals, and there's a very good collaboration between Fran and fellow commissioners in terms of getting that best practice and sharing it across Sussex and making sure that when we implement something that's innovative, that then that gets shared across the region as well. So we're quite confident that we're learning from each other and engaging with key stakeholders.
And I might quickly add, I've only recently stepped into the role of co-chair for the third work stream, but what I can say is the intention of everyone sitting in that work stream is incredibly strong. The will for everyone to coalesce around this, and I think what we've already discussed is a plurality of engagement activity going forwards, things that we need to to hear and to speak to different people includes hearing the Safe and Well at School survey responses, but we've also discussed things like Audioactive have a Truth to Power project where young people are coached to articulate things that are going on for them in their lives. And actually we need as a work stream board to go and meet them and go and see them and hear them and go and be proactive. So the intention is absolutely there and it is being built into the work plan going forward. So we're quite excited about all the engagement work that we've got lined up.
Thank you, Chair. So having been part of the Combating Drugs workshops and the planning towards strategy, I can wholeheartedly say that it is good to see this now published, but the work now starts, isn't it? Well, continues, I suppose, to be. Because I think we need to be, as Caroline said, as partners, more visible in our actions and our activities around delivering the delivery plan aligned to the strategy. So you mentioned SPFT mental health being a core component and also the acute, the front door. And we've had conversations about some of the pathways that we're starting to make a little bit more robust. I suppose my question relates to, because we also in the city have a high level of suicide rates, unfortunately, and I just want to make sure that all the sort of services around suicide prevention are linked into this work. You mentioned the multiple compound need, multiple advantages work that we're doing cross partners. So for me, it's just ensuring that we don't have this strategy in isolation, but it permeates in all of the active work we're doing, particularly at neighbourhood level. Thank you.
Yeah, just to reassure you, Tanya. So last year we undertook a drug deaths audit, and that identified about 20% of drug deaths were linked to suicide. That audit and the learning from that has fed into a suicide audit, which is just underway. It's nearly complete, actually. It's just in the last stages. And all that information in turn feeds into the multiple compound need work that we're doing. So absolutely linked up. And that's the benefit, beauty of working in partnership, because people can do.
Thank you. Any more questions or comments? I had a question, but you have almost answered it before I asked. But I think there's a part which I would like. It was concerning how the point about increasing your service, improving your service, whereby you said making people aware of the service. So I was going to ask about what tools you use to achieve that, and you have mentioned some of them. But I wondered whether, because I think it could be linked to the disappointment you had before for the minority, the contribution from the minority, if that tool isn't used well. I wonder whether you try to be creative enough with the tools you used with different types of communities. So my question is whether you have considered, or you are already doing it, working with, for example, religious leaders or such organizations.
Thank you for this question, because something happened just last week and I can answer like I know what I'm doing. So we've been contacted by, I have been contacted by women of color struggling to engaging with drug and alcohol recovery service connected with stigma and a religious approach. So this is a work that is really close to my heart and I really want to do. I have to say, it's not been easy because we have encountered multiple barriers on communication, especially in intersectionality. Women approaching service, women of a minority approaching service, women into a religious community coming from a minority and being women accessing services. Is difficult work, and we are willing to engage with religious community as well. I'm taking any lead on that. For now, what has been working the best for us is to have culturally competent workers embedded inside our outreach team and inside our services. We also have in Brighton something that not a lot of other services have. We have a health promotion team that is embedded inside CGL and is working on developing particular communication dedicated to minority. And we have worked last year with students and universities. This year we will be dedicating our effort to include minority, women, and working in partnership with Oasis. As you know, we're lucky enough to have a specific women's service in Brighton and Hove that has been open for 20 years. But again, if you want to take this conversation outside and you have some suggestion, I will be really happy to listen to that.
Thank you. Any more questions, comments? All right, thank you very much. The recommendation is that the board notes the reducing harms from drugs and alcohol strategy 2024-2030, supports the approach that the strategy is best delivered in partnership with the Multi-Agency Combating Drugs Partnership Board, and that this board retains oversight to the effective implementation and monitoring of the strategic aims and action planning to deliver the strategy aims. Does the board agree? I will go to the item number 7, Brighton and Hove Pharmaceutical Needs Assessment. I would like to invite Katie Harker, consultant in public health, to introduce the report, please.
Hi, I'm Katie Harker. Thank you for introducing me. These are the guests that have come along as well to help co-present the pharmaceutical needs assessment. We have Julia Powell, who is the Chief Executive of Community Pharmacy Surrey and Sussex, Katie Perkins, who is the Senior Commissioning Manager in Pharmacy in the ICB, and Rita Shah, a Senior Medicines Optimisation Pharmacist in Brighton and Hove. I'll just share my screen. Oh. Okay, so we are here to present the 2025 Pharmaceutical Needs Assessment. Great. Okay, so the Pharmaceutical Needs Assessment, which we'll refer to as the P&A, is the statutory duty of the Health and Wellbeing Board, and it must be undertaken every 3 years. And for this round, the chair of the Health and Wellbeing Board, the previous chair, I think it was Bruno, delegated responsibility to the Director of Public Health for responsibility of the pharmaceutical needs assessment. This is quite common practice, just so that we can sign it off without having to come back and get full approval at every point of the pharmaceutical needs assessment. So the P&A looks at how well the community pharmacy services are meeting the health needs of the city's residents. It informs the submission of applications for the community pharmacies' inclusion in the pharmaceutical list. And it also determines whether there's a need for extra premises, there's a need for extra services, or there's a need for improvements to existing services or improved access. So this round, the public health team commissioned a private company, Soar Beyond, to prepare the P&A. This is a company who's produced P&As for more than 50 different local authorities and seems to do a very good job of it. So they were commissioned to complete the P&A, but that also included significant input from the stakeholder group and the public health team, intelligence team, to provide the local health needs information. And the whole process was overseen by a multi-stakeholder steering group, including the partners here. The process included comprehensive data gathering on pharmaceutical services and population health needs, a public engagement exercise where we sent out a survey to residents for their views on pharmacy access and use, and we got 358 responses received, which were analysed. We mapped service provision across the city to look for gaps. There is now a public and stakeholder engagement on the Your Voice platform, which is a 60-day consultation. And we look at the P&A with the consideration of local strategies, for example, the Joint Strategic Needs Assessment, the NHS Long-Term Plan, and the Joint Health and Wellbeing Strategy. So key findings from the P&A was that there are 51 community pharmacies, including 1 distance selling pharmacy in Brighton and Hove, and that equates to 18.2 pharmacies per 100,000 of the population, which is, it's very slightly above the England average, which is 18.1 per 100,000. So it assessed that access to pharmacies was good across the city. 100% of residents who have access to a car can reach a pharmacy within 10 minutes, although we do know that car ownership is slightly lower in Brighton and Hove than it is in other places. But still 98.1% of residents can walk to a pharmacy within 20 minutes and 100% using public transport within 20 minutes. Pharmacy opening hours show that 35% of pharmacies are open after 6 p.m, but it's to be noted that some of those not much past 6 p.m. 71% of pharmacies are open on Saturdays, which is good weekend access, and 8% are open on Sundays, and that reflects broader trends in weekend healthcare access. So advanced services such as the new Pharmacy First system service, the new medicine service, flu vaccinations, hypertension case finding were widely offered across the city with good uptake. There was also enhanced services, including COVID-19 vaccination. Locally commissioned services, for example, emergency contraception, supervised consumption, smoking cessation, are provided across the pharmacy network. No current or future gaps were identified in the provision of essential services, and there's good access to other services across Brighton and Hove. So this is a map of the pharmacies. You can see there the 50, 40-hour community pharmacies dotted across the city, and one distance selling pharmacy, as I said, representing 18.2 pharmacies per 100,000 residents. This is Sunday opening, so it's slightly hard to see. The red dots are closed, the green ones are open, so you can see we've got the two Boots branches near the seafront there, and then we've got Asda Brighton Marina and Asda Hollingbury. The conclusions of the P&A was that pharmaceutical services in Brighton and Hove are well distributed and accessible, meeting the current needs and the projected needs of the population. No gaps were identified in the provision of necessary services. Advanced and enhanced services are widely available. The current pharmacy network in Brighton and Hove should be supported to strengthen service delivery, particularly through improved public awareness, enhanced uptake of enhanced services, in areas of need and alignment with other health priorities. And that's something that we're already currently working on. And there was a closure of a pharmacy in Rottingdean, which has affected local residents, but on analysis, it did not represent a gap in access to pharmacies. So the next step is, as we're currently undergoing a mandatory consultation, and that was launched on the Your Voice platform on the 26th of May, and it will close at the end this Sunday, 27th of July. Any comments will be reviewed and a final version of the document will be produced. We've already received, I think, 9 submissions on that platform. And then a report on the consultation will be included in the final version of the document. As previously noted, the Director of Public Health has delegated authority to approve the P&A, and a full and final P&A report will be presented to this meeting at the September board. Thank you.
Thank you for the report. Any questions, comments? Yes, Steve.
Yeah, thank you very much for the report. And I think certainly in absolute numbers terms, it's good to see that we've got at least the average number of pharmacies in Brighton and Hove compared to the England average. I suppose I had 2 questions. I wasn't clear how the opening times compared with the England average, because obviously having the facilities is one thing. If they're not open as much, then still access to services is potentially reduced. And I'm also interested, and maybe Julie will be able to answer this one, in terms of how we could increase the uptake of Pharmacy First, because I do think our community pharmacies are a really important asset in our communities. And I think actually in reality, the uptake of Pharmacy First is quite modest, if I'm honest, in terms of spreading workload across the entire system. So a couple of questions, if that's possible. Thank you.
Regarding the opening hours, I believe that it's similar to national, but I would have to look at the P&A because I haven't got that data to hand, unfortunately. But I believe it is similar. I don't know if you know. I can look it up quickly in the P&A.
So I'm not aware that there is an England average for opening hours and distribution across England. We can double check it, but I've not come across one previously that's been quoted. And then just in terms of the second question, so around Pharmacy First, the uptake across Sussex is average if you look at it compared to the other ICBs across England. There is definitely room for improvement. So I think we could be seeing a lot more access of Pharmacy First through the community pharmacies, both through referrals from other healthcare professionals, but also from awareness from the general public that they can actually walk into the pharmacy for 7 clinical conditions and obviously be seen and then treated appropriately with an NHS funded treatment if that was appropriate for them following that consultation. what we have been looking at across Brighton with our Community Pharmacy Forum group, which has representatives from the ICB, Public Health and the local pharmaceutical committee, is obviously what we can do to increase that awareness with the public. One of the things that we have been very fortunate with is working across Brighton, some of our integrated neighbourhood teams. We have been working very closely with some of our voluntary sector organisations, so particularly the Trust for Developing Communities, and also support from the council. We have produced leaflets and posters advertising the public health services, as well as the locally commissioned services such as Stop Smoking and the sexual health services, just trying to get the awareness out there to the public as much as possible. We are looking at further communication campaigns, so there are some new comms that are coming out shortly. They have been launched on the website, and we are trying to get that message as far and wide as possible, both with our healthcare professionals to refer in, but also with that awareness around the general public.
And just a note on opening hours, I can't see anything to say what the sort of average is, but it's something that NHS England might be able to provide for us. So I can ask them and get back to you if you want to compare.
Thank you. Any more questions? Yes, please.
Thank you, Chair, and thank you for the report, guys. My question is about the important role that, following on from what Stephen was saying, really, the important role that pharmacists play in the community, neighbourhood level, and connecting the public to wider services within the city, including the community and voluntary sector, for which I'm a representative. Is there any data being tracked around the sort of the number of referrals that are being made by pharmacists locally and then comparatively on a regional or national level, so we can track how engaged pharmacists are with that process of signposting the public to services? And then also, how can sector colleagues of mine engage with forums like the pharmacy forum you mentioned there to perhaps raise awareness of different service user groups and the services that are available to them, so that we don't have to go piecemeal to the individual pharmacies to try to raise awareness, in my case, of unpaid carers, for example?
We'd definitely be happy to invite you along to the Community Pharmacy Forum if you want to come and talk about it. Do you want to take the other question?
Yeah, so just in terms of the signposting to other services that you mentioned, the community pharmacy contractual framework, one of the essential services within that is actually signposting to other healthcare professionals or other organisations to support patients with their needs. So that is very much a fundamental part of our actual role within community pharmacy. In terms of looking at analysis or numbers, we do collate signposting information, but only where there has been perhaps a major signposting. So we do it so often on a daily basis that we don't collate numbers on a regular basis for all of the signposting we do. Certainly, though, if you did want to come along to the Community Pharmacy Forum, what I can do is obviously collate some local information just around what the key organisations are that are signposted across Brighton and Hove, and then obviously perhaps look at where there could be some that are missing, that we could get that communication out to pharmacies to ensure that they're all aware of other opportunities for signposting patients too as well.
Thank you. Yes, please.
Thank you, Chair, and thank you for the presentation. A couple of questions, observations. One around the opening hours. I was just wondering about early opening hours for workers on the way to work, and whether we have any data around that, because that's obviously a critical time for many people. And with pharmacies, and the 10-year plan talks about expanding role of pharmacies going forward, and Pharmacy First is likely to expand as well. So there's a huge impact they can have for diverting people away from other critical services, especially A&E. And I suppose it's that gap around Saturday evenings and Sundays, which then puts more pressure on our A&E services. I know that isn't really your gift, but I think it's worth understanding how some of the contractual challenges restrict that. Could you perhaps explain that? Thank you.
Do you want to go? I believe it's been looked into before, hasn't it, about increasing the hours, but was found to be prohibitively expensive in some areas. But
Yeah, so if there is determined to be a need, so obviously the ICB can look at the stakeholders, they can look at the activity in those hours, such as evenings, Saturdays and Sundays, and there is the opportunity obviously to have a locally commissioned service, so community pharmacies can be directed to open, or they can obviously be part of an enhanced service and open that way. We do it at the moment for bank holiday openings, so we do it for days like Christmas Day and Easter Sunday and things like that. That can obviously be extended out. When we have looked at it previously, there hasn't been a need for it, but obviously that is something that the ICB could take away and look at again and review whether, with any changes moving forward, there is a need for that.
But it would also need to be funded.
Thank you. I think that's really worth looking at, because I think that partly helps to avoid the scramble on Monday mornings for people who need help when they might have actually got that help from their pharmacy on the Sunday or Saturday, and people who are in crisis like the weekends, or perhaps not necessarily severe crisis, but help they could possibly get from their pharmacies rather than their local A&Es. And there's, sorry, another question, if I may, just around the number of people who responded. I know it's very difficult to get people to engage in something like this, but 350 is quite low given the population of the city, but I was just wondering if you could explain some of the demographics of who actually replied to the survey. Do we feel that we've captured enough views from across the city? Thank you.
We sent the survey out through a lot of our community groups. We did push it as much as we could. We had paper copies in case there was people who felt that they didn't want to access it digitally. We sent it out to various community groups, and we went along to a lot of engagement, a lot of health events with paper copies and QR code to link to the survey. We sent posters out. Yeah, I mean, I agree. It would have been better to have a larger number of people, but we did put a lot of effort into trying to get that feedback.
Thank you very much. And any more questions or comments? Okay. The report recommendation are that the board notes the draft pharmaceutical needs assessment report and identifies any additional information required to inform its decision on the final version of the pharmaceutical needs assessment when it comes to the board for approval in September 2025. Does the board agree? The next item on the agenda is NHS reform. I would like to invite Stephen Lightfoot to present the report, please.
Thank you very much, Chair, and also good afternoon, colleagues. So my name is Stephen Lightfoot. I'm the Chair of NHS Sussex Integrated Care Board, and the paper I've written, which is on page 71 of the pack, is intended to give you an overview, really, of the number of NHS reforms that have been announced in recent months. And I thought it would be helpful to basically show the journey over the last year, because this has been coming for some time. I think obviously a year ago, just over a year ago, a new government was elected through the general election. And one of the first actions of the new Secretary of State for Health and Social Care was to commission an independent investigation of the NHS. It was conducted by Lord Darcy, and he published his results in September 2024, when he concluded that the NHS is in a critical condition, but its vital signs are strong. But I think actually what that meant was more significant reform was required. The government then launched the biggest public conversation on the future of the NHS that helped to inform the government's 10-year health plan during the winter of 24-25. And NHS Sussex ran a number of engagement events in Sussex with both the members of the public and also with our staff during January and February to support that particular process. Then in March, the government announced the abolition of NHS England, which will happen in the next 18 months to 2 years. And also that every integrated care board, like NHS Sussex, has to reduce its running costs by 50% by the end of this particular calendar year. And when I talk about the running costs, I'm talking about the running costs of the Integrated Care Board, not the entire NHS budget that delivers healthcare services across the county. In April, the new leadership team of NHS England then were doing some analysis of actually comparing the funding that's given to each system compared to a national fair shares allocation. And that analysis identified that Sussex is currently being overfunded by £186 million. So just to put some context to that, we currently spend about £4.5 billion on NHS services in Sussex. But actually, the analysis is showing that it should really be £4.3 billion. So we're talking of a 4% overfunding, which does not sound a lot on a percentage basis, but £200 million is a significant sum of money. And actually, over the next 3 years, when our demand continues to increase, we're going to have to reduce our expenditure. And I think we're going to have to work very hard to make better use of the money that we have. Then in May, we were given what was called a model ICB blueprint that was produced by the national team. And we were given 18 working days to develop a proposal for how Sussex is going to respond to that and submit that to NHS England by the end of May. Now, our proposal, which has now been approved by ministers in the Department of Health and Social Care and the Ministry of Housing and Communities and Local Government, is to create a new integrated care board for Sussex and Surrey, which is coterminous with the proposed mayoral combined authorities for Sussex and Surrey. And the reason for doing that was the best way to meet our statutory duties within the financial budget we were given. We felt that was the only safe and reliable way to continue to deliver our services that we're currently doing. So as this proposal has now been agreed, we're now working to establish a board in common across both of the current integrated care boards for Sussex and Surrey, and that will come into operation from the 1st of October, with the aim of significantly reducing our total headcount from the current 1,350 people employed across Sussex and Surrey Heartlands ICBs. And the intention is then to establish a new single integrated care board for Sussex and Surrey from the 1st of April. So that is the timescales that we're working towards. I cannot underscore the massive scale of this task, but also the huge impact it's having on our staff. So 1,350 people who are worried have they got a job. And of course, a significant number of them will not have a job in the coming year. And I think the thing is we're not alone as well, because as already been mentioned, in advance of the 10-year health plan, the government also confirmed that it's going to rationalise all patient safety regulators. And obviously that involves also health watch organisations who are going to be closed. Not immediately, but over the next 18 months to 2 years, probably. So again, like colleagues, from a personal and organisational point of view, I've got to say I'm disappointed. And I'd just like to formally record my thanks to everything our Health Watch partners and also importantly their volunteers, because there are many volunteers that work for Health Watch, everything that they've done to engage with patients and provide the really vital insight that's helped to improve our services here in Sussex. And specifically, I would just like to mention the support that we've had in improving access to GP services in Brighton and Hove. And also, the recent award-winning engagement campaign around the development of a new non-emergency patient transport service across Sussex. So, Alan, on behalf of myself and my colleagues, we really do appreciate everything you've done for you and your colleagues, and we wish you well, and we know what it feels like. Having said that, there is also a number of other things going on. So the 10-year health plan has now been published. And I think on a positive note, it does provide a clear direction in terms of moving more care from hospitals to the community, making better use of technology and investing more in the prevention of illness. And I'm glad to say that they're all consistent themes in our Improving Lives Together strategy. So I think the good news is that we don't need to have a significant change in strategic approach within this particular health and care system. So I think that we can build on our Improving Lives Together strategy to implement the 10-year plan. I'm also really pleased that in the 10-year plan, the health and wellbeing boards, such as this one, are going to be retained. And I think that will also help to maintain a focus on local priorities. And that, I think, is really vital. And I think actually in the 10-year plan, it suggests that the health and wellbeing boards will need to draw up a neighbourhood health plan, which again is completely consistent with our approach around the development of integrated community teams. So I think actually, despite all of the change, it feels that we're on the right track, and we've just got to treat our people well and enable the changes to be made as quickly and as effectively as we possibly can. So that's the current status. Obviously, I can try and answer any questions that there may be, but that is a summary of what's happening within the NHS at the moment. Thank you.
Thank you, Stefan, for the report. Do we have any questions or comments?
Thank you, Chair, and thank you, Stephen, for that summary. I think the pace of change is phenomenal, and it's almost hard to keep up with the pace. Your staff, including the people here, we have our support, and it's a very difficult time for you to go through, so do reach out if you need anything. I think there'll be some reassurance needed for the public in relation to these changes, to reassure them services will still be there. This isn't going to suddenly stop the provision of services, but they will have questions as soon as you mention reduction of money. Patients, members of the public get concerned around services disappearing, so I think we need to bear that in mind. If I may just take a minute just to talk about the proposals for Health Watch. I won't take long, but I just wanted to highlight that we're incredibly disappointed, and we do think it's a rather short-sighted decision. The Health Watch network is coming together to challenge the decisions best we can. We're not challenging the loss of Health Watch per se, we're challenging the loss of independent services and scrutiny that we provide. If this change goes ahead, it will be the first time since 1974 that those services won't exist, which is quite a change. It's hard to understand how the transfer of our health functions to the ICB and our social care functions to local authorities support the idea of integration. You can't separate people's health and social care experiences. That just isn't possible. So we do have some concerns around how people's feedback will be captured and also cross-referenced. I think we've also had a lot of support from members of the council, from councillors, from the ICB colleagues, from members of the voluntary and community sector, and members of the public. I haven't heard one dissenting voice saying this is a good idea, so I've had questions around whether it's actually supported. And I do question the fact that the public haven't been consulted on the abolition of an independent service, which is there to support them. And I also question the way we're going forward with independence. Yesterday, the Prime Minister announced an independent ethics committee, and within the Penny Dash report, it talks about the need for independent functions for the Freedom to Speak Up Guardian and the health services, the HSSIB, can't remember the full title, sorry. So it's important for them to retain their independent functions to a degree, but no independent functions for patients. And I find that difficult to accept. Should the change go ahead, we will work professionally and with integrity with our local authority colleagues and ICB colleagues to make sure that the roles we perform are not lost and the patients are continue to be represented. And I want to thank colleagues all around the table and beyond for their support. So yes, Health Watch will remain until that isn't the case, but hopefully there'll be some future format to take over from us. So thank you, Chair.
Just to follow on that, I think from a commissioning perspective, the voice of the patient is absolutely critical. So I don't know what the solution is to that yet, but I think we want to work collaboratively to make sure that the voice of patients is involved in every single service change that we make. We cannot make them independently of the voice of the patient. I think just to come back on your question around the reassurance around services, there's one thing I did forget to mention that is included in the paper. Our proposal to go with a Sussex and Surrey Integrated Care Board is predicated on the fact that we'll have one Integrated Care Board, we want to retain 2 systems, one for Sussex and one for Surrey, which would of course be coterminous with the combined mayoral authorities in Sussex and Surrey, because I think we need to accept that the systems are currently operating quite differently, and I think we need to reflect that local difference, and also to retain 5 places, assuming there will be 5 unitary authorities. I know that is not fixed yet, but at the moment there is talk of 2 unitary authorities in Surrey, and there could be 3, 4 or 5 potentially in Sussex. So I think that these changes do enable us to make sure that we have services designed around places and unitary authorities to bring together health and social care in exactly the way that you were describing, Alan, because the two are inextricably linked. I think in terms of thinking about service change as well, we are currently working towards, as NHS Sussex, to publish our commissioning intentions for next year at the September Integrated Care Board. So we're working to have the commissioning intentions identified quite clearly. And also, just to reassure you that if there were to be any service changes, they will need to be public consultations. And so again, that will be something we would want to do because that's the right and proper thing to do. So again, I think we're going to have to figure out how we make the money work, but we want to do this in collaboration with, not to, the population that we serve. Thank you.
Thank you, Stephen. Thank you. Do you have any more questions or comments? No? All right. The recommendation is to note the report. Does the board agree? The next item on the agenda is Director of Public Health Annual Report, a whole city approach to healthy weight. I would like to invite Caroline Vaz to present the report.
Thank you, Chair. And like all our reports, it's a collaborative contribution here. So I'm going to introduce and give some slides on the Director of Public Health Annual Report, and then I'm going to hand over to Katie and Roisin, who are going to talk us through some of the recommendations that have come out of that report. I'm also going to play a little video. So this will be testing the tech a little bit. But just to introduce it, the Director of Public Health Annual Report is a requirement that was set out in the Health and Social Care Act in 2012 that all directors of public health undertake an annual report on a topic of interest or concern for the local, for their residents. And so this is the annual report for 2024. They're hardly ever in the same year. And what it does, it describes our one council and whole city approach to managing healthy weight. But what I'm just going to do first is introduce just a little video that talks a little bit about what this means for us in our city. So bear with. We have tested this and it did, we think it works. Right. Oh no, there's no sound.
Just on
mute. No, we've tested it when it comes through here. Right. James isn't here. Eek. Sorry, hang on. Oop. Okay. Right, I will have one more go at this. It's such a good video. Right, that's what I have to do.
Being a healthy weight is good for our physical and mental health. In Brighton and Hove, over half of adults and a third of children are overweight. Eating healthy food and being active are important for maintaining a healthy weight, But staying a healthy weight from childhood right through to old age isn't easy in the society and the environment we live in. Our local data shows that the likelihood of being overweight is higher for some groups and in certain parts of the city. For example, in some of our schools, 2/3 of 11-year-olds are already overweight or obese. There's so much we can do across the city to help make the healthy choice the easy choice for everyone. It's the houses, the streets, the communities, and the city where we live. It's our parks and our seafront. It's where we eat, what we eat, and who we choose to eat with. It's where we shop, what we can afford, and how that food is advertised and promoted towards us. It's where and how we travel in and around the city. It's about making it easy to walk, bike, bus, or scoot to the places we need to go. It's where we work and what we do while we're there. It's where our children and students learn and develop their habits for life. It's where we play and spend time relaxing with our friends and family. But it's not just good for our health. It benefits our environment, our businesses, our economy, and our whole city too.
Riding my bike is good for my health, keeps the air clean too.
Working together, we can make sure that Brighton and Hove is a city where making a healthy choice really is an easier choice. What do you think we can do together?
So I am now going to share my slides. So ideally I would have embedded that in my slides, but that way madness lies, and I was trying it, so. Okay. Okay. I've lost. Right now, I need your help. I've lost the full screen.
Halfway along the slideshow. Next animations.
Lovely, thank you. It's a different place from the other one. Before I do anything, I would like to acknowledge the contributions of everybody who has helped to pull this report together and, more importantly, enable us to take a whole city approach to our Healthy Weight programme. So in particular, I want to thank members of the public health team. We've got Katie coming here and Roisin Thurston, also Kate Gilchrist and Sarah Bryce, who made the report look absolutely fantastic. So Sarah's in our design team. So I've talked about the requirement for the Director of Public Health annual report. So what we've done in this report, the report's attached in the papers, and I am just going to go through each of the chapters. So the first chapter helps make the case for healthy weight. It talks about the preventable long-term conditions that come with an unhealthy weight. It looks at the economic impacts of obesity and about the increasing widening inequalities in our society. I love this graphic. So this describes, in this chapter, describes our journey towards a healthy weight, and it starts over the last 20 years. So it starts in 2023 and it comes up to 2024. And you can see on the sort of under the journey are the national indications, and then on the top of the journey are our local activities and innovations across the city. And you'll see some of those things in here, like the Sugar Smart. So right in the middle there, that Sugar Smart in 2015. That led the way for other local authorities to undertake similar activities and influence the national approach to reducing sugar in drinks. So, you know, there's some work that's gone on in our city that we're extremely proud of. So we then go through what a whole systems approach is and how one can go about developing a whole systems approach. So this annual report also acts as a kind of toolkit and signposter as well to explain how you might go about that process. And then we talk a bit about how we deliver that whole systems approach, taking a life course journey in Brighton and Hove, and we look at the first 1,000 days, school years, young adults, working age, and then embed that within the whole city. So as we said in the little video, the aim is to make Brighton and Hove an easy place to take the right decisions to help maintain your healthy weight. So those are the initial chapters, and then we go on to the recommendations. And I know that Katie and Roisin are going to talk a bit more about the recommendations that come out of this. So you give me the nod, and I'll move the slides along.
Oh, sorry. Hi, my name is Roisin Thurston, and I'm a Senior Health Improvement Specialist with the Public Health team working on the Healthy Weight Agenda. I'm going to talk us through a couple of the recommendations and then hand over to Katie. So when we were looking at the recommendations, we decided to keep the same structure as the report using that life course approach. So we're going to start with early years. And knowing that it is important for pregnant people to be a healthy weight because it prevents against things like diabetes and high blood pressure, and then leads on to further complications. So having that support for pregnant parents and for families at a young age is really vital. We have really good initiatives in the city, such as the WHO Baby Friendly Initiative. We also have weight management support for pregnant people as well. But there's more work to do around these areas, particularly working with those who are most susceptible to these issues from a health inequalities perspective. In terms of we have a really excellent specialist breastfeeding team as well, who offer community-based programs for families to support them to make those healthy choices from a young age. And there's room to build on this as well. So moving that approach into businesses and workplaces that will support those healthy attitudes and healthy lifestyle choices across the board. We know that from our NCMP data that 1 in 5 children who join reception year are an unhealthy weight. So there's lots of work to do in our early years centres, be that maybe our family centres, our council-run nurseries, our private nurseries. They can all adopt a healthy approach that will encourage parents and families to have a healthier weight, particularly policies around food and activities within those centres. And they will support lifelong health and well-being. If you could move on to the next one. Thanks, Karen. So then moving along to our school years. So again, schools are a key environment for our children and young people and for families as well. And you can see there on the right-hand side of the slide, the recipe for a healthy weight school. It lists different elements that can be considered to support schools to be a healthy weight. But it's not just about what happens inside the school, like leadership policies or healthy lunchbox policies, active lessons. It's also the environment that surrounds the schools and the businesses that are around those schools as well that make it, that can help or hinder families to have healthier choices when moving to and from the school as well. Really important to focus on our healthy, affordable, sustainable school meals and making them accessible to all those who need them. And when they do access that food, that it's really good, nutritious food that they're getting as well. Unfortunately, as we move from our reception data, or what our reception data to our year 6 data shows, is that we move from 1 in 5 children being an unhealthy weight to 1 in 3. So that's a significant drop across that period. And that's why this setting is really important for a whole system approach. And when we did our workshops as part of the whole systems work, a lot of people identified schools as a key area and as a key setting where lots of work can be done. So the willing and the desire is there to change it. It's just about making those changes and making them as healthy as possible for that development and lifelong habits for young people. Moving over to Katie.
Thank you. Next slide, please. Yeah, so in terms of businesses, workplaces and working age people, our recommendation is to work with the Chamber of Commerce and lots of other business networks to support any business or workplace to become a healthy workplace, thereby helping, enabling the employees, but also customers to access healthy and affordable food during the workday or the working hours, recognising that those who are working antisocial hours, night shifts, difficult shifts in terms of the rest of their life may also struggle to get good food easily during their working hours.
Businesses can support employees to move more, both through the active workday, but importantly on the way to and from work through active travel. And they can also adopt active design principles to make workplaces as active as possible. Really important in terms of making the case for businesses. It's good for health, but it's also really good for business too. If we've got active businesses, productivity is better, sickness absence rates are lower, so it absolutely is a win-win. Next slide, please. So Let's Get Moving is our physical activity strategy, which has come to this Health and Wellbeing Board a couple of times in the last 18 months. And this is really central to our approach in the city to help everybody maintain a healthy weight. We want to promote and support people moving more right through the life course, so from pregnancy and early years right through to older age, with a real focus on those groups who struggle most with inactivity. You can see along the left-hand side of the slide here the 5 pillars, which are based on the WHO pillars and are part of our physical activity strategy. That's an active culture, active people, active communities, active environments, and active systems. And those really are critical to our approach. And there on the right, you've got a picture of the strategy, which is the 10-year strategy, and some of our brilliant green spaces, which really do support everyone to be as active as possible. Next slide, please. So in terms of planning, there's lots that we can do with planning to support healthy weight environments. We can integrate healthy food environments to lots of our urban planning and public spaces. We've got the opportunity to really explore and integrate planning mechanisms to restrict the density of less healthy food businesses. And we know that we've got one of the highest numbers of fast food outlets per head of population in the southeast. This is getting a lot of publicity recently, with a lot of resident and local schools objecting to the proposals for a drive-through McDonald's close to a number of schools on the old Shoreham Road. And health and wellbeing is really central to the City Plan 2041 consultation that took place recently. We know that there's lots that we can do, as mentioned already, to incorporate active design principles into formal planning as well, and this really supports healthy weight and also reducing inactivity, in particular through supporting the walkability and cyclability of our city. We're reported to have one of the most walkable cities worldwide recently. I think the Time Out report stated, but our stats do show that a very high proportion, in fact, the highest proportion of residents in the country do walk or cycle to work at least 3 days a week. So we're basing this on a good record. Next slide, please. In terms of action on advertising, marketing and promotion, we all know it's important. We've got the opportunity to build on the recent high-fat, salt, sugar advertising restrictions that the council voted in the last couple of years and that are being introduced with the new bus shelter advertising contract in September of this year. These aim to reduce children and young people's exposure to unhealthy food and drink advertising, but there's a lot more that we can do, including on our high streets generally. You can see the adverts there on the right. England are playing Italy in the semi-finals later this evening, and our advertisers don't miss the opportunity for Pepsi to promote. Now you can see Thirsty to Bring It Home with Leah Williamson and Lauren James promoting the benefits of Pepsi for anyone who's keen on watching. It can be difficult, but as mentioned already in Caroline's introduction, we have played a role in trying to influence the national picture around some of these policies and practice, but there are also things that we can do at city level. Amsterdam have really helped sort of pave the way and provided a very strong example of a city that's taken a strong stance on trying to improve the healthy weight environment for their residents. And they brought in a policy of no sponsorship or promotion with unhealthy food and drink brands for sporting and leisure events where the main audience was children and young people. So I think they had a threshold of about 25%. And if it was more than that was expected to be children, families and young people, then they restricted unhealthy food and drink brands. Next slide, please. So, healthier food offer out and about. I think everyone knows that we're eating more food out and about, and in some cases ordered into our homes than we ever have done before. There are real opportunities around healthy, affordable and accessible food offers in our public sector premises. So we've got good food standards, that's covered in the report. And through procurement, we can really influence the offer that's available for people of all ages in the city. We know that we can use price, but also sort of placement to promote healthy, affordable meals in lots of our public sector premises. And that includes schools, workplaces, etc. I think anyone who spends time in our hospitals, in our schools and colleges, and also in our sports facilities know that vending is often the means through which we're offered and sold food. And a lot of that offer is far from healthy and sustainable. So there's a lot that we can do there. You can see on the bottom left of this slide, our Brighton and Hove Food Strategy Action Plan, which also came to the Health and Wellbeing Board. And lots of the recommendations of this report are very much in line with that next 5-year action plan strategy. So as Roisin mentioned, a real focus around schools, but also that option to make sure that anywhere which is selling meals while we're out and about has one healthy, affordable, sustainable option. You can see again on this slide one of the 6 water fountains which the council and partners, including the Biosphere and Southern Water, constructed in the last few years so that anyone who's out and about in the city can refill their water bottle rather than having to buy drinks, including sugary or less healthy options, in a single-use plastic bottle. And in terms of the healthier food offer when we're out and about, we do want to support those businesses to offer healthier choices through an accreditation scheme, like our current Healthy Choice scheme. We know from residents that it can be quite difficult to spot the healthier options when you're looking at a counter or a menu. So we want to continue to promote any citywide adoption of food labelling to make that a lot easier. Final slide. So now it's just open for any suggestions for further commitments for our whole city healthy weight work. Thank you very much.
Thank you for the report and for the great work. I didn't get the chance to thank you personally. And any questions or comments?
Thank you. Thank you very much for preparing and also producing the report, Caroline, and the rest of the public health team. I think it's a really important topic, and it's one not to underestimate the impact on long-term health conditions. And certainly I've been part of the food strategy before and really committed as an NHS partner to ensure that we're working alongside our public health colleagues, our VCSE sector colleagues, to ensure this messaging is out there. On the sort of younger age school, there's also an element, and I think it was mentioned on the food strategy, just about what measures we utilize to for young people, children and young people particularly, to estimate what's a healthy weight. And I know we mentioned at that same, when it last came on the food strategy itself, around just ensuring that BMI is not the only methodology, because it can also cause challenges, especially for young people who are very athletic. And I mentioned the minoritized community, particularly, and personal experience when my daughter, who's very muscular because she plays lots of sport, was indicated in her report that she was on the non-healthy weight. And we know that she is extremely healthy. So there's just an element of let's make sure we don't also set our young people up to start to have body image challenges, and just ensure schools sort of the messaging is supported through SCFT, Community Trust, who do some of the services in schools, but also through the public health messaging. Thank you.
Thank you. Yes, Grace.
Well, thank you very much for the report, and you really shine a light on something that's really important. So thank you very much for doing that. And I think we can be really proud of the number of different things that are going on here. So I think it genuinely should be a sense of pride for the city, genuinely. So thank you to the team. I had a slightly different perspective of something that I was interested in, and that's actually the role of weight loss medicines in terms of healthy weight. And I guess, properly prescribed in certain situations when all other actions have actually failed, there's no doubt that weight loss medication can have a role to play. But I do worry about people buying these on privately, without proper medical supervision. And actually then the inappropriate use of weight loss medications. And it seems to be very popular at the moment. And I just wonder whether we need to think about the responsible use of weight loss medication as part of an overall plan such as this. I'd just be interested in what your view is, Caroline.
I absolutely agree. I mean, I think there is a place for them, but I think there's a place for them within a context of a healthy environment and a non-obesogenic environment. I think we're learning more and more about the impacts of them and the risks, and what happens when people stop using them, what happens when people are accessing very cheap medications online that maybe not exactly what they purport to be, and there are issues associated with that. So there really is something about that regulation of it. But how we bring in this product, which it's out there now, I mean, into a healthy weight approach and a more kind of integrated way of managing it. I mean, the data are coming through thick and fast about the evidence and the impacts, and we're learning more and more about this. I think this is something we need to keep our eye on. Absolutely.
Thank you, and thank you for the presentation. It's a really good report, and it's very engaging as well. So thank you for that. Just one quick question. The Health and Social Care Committee have just launched an inquiry into weight management, food and weight management, which is actually looking at ending the obesity epidemic. Are we as a city going to submit to that inquiry? That was my first question. And I was just struck by the report in relation to, I think you call them anchor organisations or businesses. And I don't know whether this feeds into the slide you talked about, but much as organisations can take steps to become dementia friendly and then get a certificate, I wondered if we can sort of roll something out similar, so organisations can take steps to demonstrate they're offering healthy choices and then get some sort of certification, because organisations do appreciate that. So that's just something to maybe consider. But yeah, thank you.
So we haven't discussed submitting anything as part of that consultation, but it's certainly something that we could do. And certainly, I think over the last 10 years that I've worked here, we have quite often shared a combination of both views, but sometimes we have been asked to share some of the sort of more innovative developments here in the city as part of that sort of national consultation process. So we could look at that. So I could hear some of what you were asking in the last thing. I think it was to do with the slight interference on the thing, but it was to do with their anchor institutions potentially taking steps and then acting as a role model for others. Was it? I'm sorry, I'm probably too close to that as well.
Yeah, no, it was just as in the city, we're a dementia-friendly city, so and organisations can then take steps and submit evidence to show that they have done that, and they can then get like a certification or something they can put on their website to say that they are. And I just wondered if we could do something similar for businesses so that they can demonstrate they're taking steps, and then they can flaunt this fancy badge that we might be able to give them, and that might just start encouraging more to do the same.
I think that's exactly the sort of interest and commitment that we want as part of this process. So we mentioned the Healthy Choice Award, which has been running for a number of years. We're a city with lots and lots of food businesses, into the many thousands. And I think particularly probably with recent challenges coming through COVID, cost of living crisis and so on, there has been a bit of a struggle to engage some businesses in some of the measures that they could take. So I think we're probably at the point now where we need to sort of review some of the approach and what fits. And I absolutely agree. It's about, the Healthy Choice Award had a commitment and then it had an award. And, any business could sign up to the commitment and make one or two changes, and then they had to do a bit more to get that full accreditation. But we're very keen in the way that dementia friendly and other work areas do have accreditation schemes to work. And not just with the smaller food businesses, with some of those much bigger organisations. And I think, healthcare settings, the irony, we've highlighted it in some of our previous work, the fact that not quite as bad now, but in years gone by, and certainly, myself remember working in hospitals where The food offer for staff wasn't always fantastic. The food offer in the shops, the cafes that people attended just before going to the outpatient clinic where they were being treated for diet-related disease, that there's a lot more that we can do, I think, schools, healthcare settings, and a lot more to walk the talk. So yeah, we'd like to do more of that.
Thank you. Any more comments, questions? The recommendation is that the board notes the Department of Public Health annual report of 2024. Yeah, no. And acknowledges the continuing commitment of all partners to make Brighton and Hove a place where it is easier to maintain a healthy weight. Does the board agree? The next item on the agenda is Health Count publication, Health and Wellbeing Partnership event, the next steps. I would like to invite Kate Gilchrist, Head of Public Health Intelligence, to present the report.
Thank you, Chair. I'm actually covering for Kate today. My name's Louise Knight, and I'm part of the Public Health Intelligence team in the Council. And I'm joined by Professor Nigel Sheriff from the University of Brighton, who's online with me, and Chaz Walker, who I think is in the room, who's our Programme Director for Integration. So we're going to talk about Health Counts publication, the Health and Wellbeing Board partnership event, and the next steps. And we're asking the board to note the publication of the Health Counts report and support the next steps and the partnership approach to these steps. Thank you. So the Public Health team has commissioned the Health Counts survey for adults aged 18 and over for the last decade. So that for once a decade since 1992. And 2024 was the largest survey to date. And we thank all of the residents that took part and all the partners involved in the research. You can see at the bottom there's a list of the different partners, and many of which are here today in the room. It provides some of the best evidence on our population in the city, health and wellbeing trends over time, and shows stark inequalities across the city. This is both by geographical area and for communities of identity. So some of the findings that Nigel will be presenting today are not an easy read. It covers some very sensitive topic areas, and it also evidences sort of deep inequalities and discrimination faced by some of our most vulnerable communities across the city. So the 2024 survey includes some new questions, reflecting the important public health issues within the city. So this included gambling-related harm, suicidal thoughts and attempts, harassment and hate crime, alongside access to nature and other natural environment questions. So the launch of this report is really just the first step. There will be further profiles by areas, so geographical areas across the city, and also by community of identity, so that's population profiles, as well as a really unique opportunity to provide robust evidence on intersectionality. And also the team and the partners are very busy disseminating results and presentations and engagements, for example, with the health forums. So this evidence is really crucial and will inform the planning of our joint strategic needs assessment, that whole programme, but also the delivery of the joint health and wellbeing strategy. So we also wanted to mention that the public health team, in partnership with the University of Sussex, do a survey every 2 years with school pupils. This is the Safe and Well at School survey. The next survey is due in autumn this year. And we propose to hold a similar Health and Wellbeing Board partnership event that focuses on children and young people's inequalities in 2026. Okay, thank you. Nigel, I'm going to hand over to you now if you're able to share your screen.
Yeah, lovely. Thank you, Louise. Let me do that
Thank you.
I think you need to stop sharing yours first, though, possibly.
Okay. There we go.
Thank you. Okay, hopefully everybody can see that. So I had the privilege of leading the Health Counts 2024 team in collaboration with all the partners that Louise has already outlined. So some of you will have heard what I'm going to say already if you were at the Health Counts launch, so apologies if you're hearing it for the second time. But for those who haven't, hopefully it will provide you with a bit of context. So as many of you will know, in planning for the Health Counts, we considered a huge range of options to generate an appropriate sampling frame for the city, which was surprisingly much more difficult than we originally anticipated for lots of reasons, including things like GDPR, which wasn't in place at the time of the last Health Counts. So we ended up adopting a whole population approach, and that meant our sampling frame became everyone over 18 without the national data opt-out who were registered with a GP practice. As you probably know by now, every GP practice in the city took part, which is absolutely fabulous. And they sent out 2 text messages during that survey launch. And we developed a city-wide promotional campaign. It was quite fun seeing those bus stops with the images that Katie just presented, because we had the Health Counts on those as well. We also had a whole programme of supported completion to engage with those who we thought would be less likely to complete an online survey. So, for example, refugees and asylum seekers, or homeless people, or those who may be digitally excluded. So we were very pleased with a fantastic rate of over 7% of adults in the city giving us around 17,000 weighted sample and around 26,000 responses unweighted. Now, Health Counts was structured around different public health issues. Some were based on the previous Health Counts questions and topics, but we also introduced some new areas that hadn't been asked before, so like gambling and suicidal thoughts and attempts, harassment, hate crime, and so on. Obviously, I can cover just a few of these, but the summary report does cover all of these themes, and there is a link here also to the full report. Now, as you would expect in any good survey, we ask a lot of demographic questions, but because in addition to health and wellbeing indicators, it does also give us really critical evidence on different population groups in the city, including evidence on those groups that we've not had before. So, for example, adults living in care, having ever lived in care, sorry, as a child or a young person, but also adults living in temporary emergency accommodation and neurodivergent adults. Now, in general, the Health Counts data, demographic data, was very similar to the Census 2021, which gives us a lot of reassurance that that weighted sample is representative of the city population. I outlined this at the launch event, but I think it's worth reiterating again here. There were some differences, and perhaps the largest difference was around the considerable underestimate of the LGBTQI plus population in the census. And firstly, that was because of the way the question was asked. So the gender identity question is cognitively very difficult to answer if you speak English as a second language. And secondly, we're aware that many LGBTQ plus people may not have felt comfortable in answering the sexual orientation and gender identity questions in the census due to it being identifiable. So in Health Counts, it was anonymous, and we also based our gender identity question on the guidance from the Scottish government, which avoids those cognitive challenges in the census question. So we ended up with much higher estimates for LGBTQI plus people in the city, which we are happy is more representative, likely to be more representative of the city's significant population. So trans non-binary intersex for the city was 5% overall compared to 1% in the census. And when you look at that by age, we see more young people reporting being trans non-binary or intersex, around 15% of 18 to 24-year-olds, and around 7% of 25 to 34-year-olds, and 0.4% of those over 85. 28% of respondents identified as being LGBTQ plus compared to just 11% in the census. By age, again, intersectionality, this ranged from around half of the 18 to 24-year-olds to around 13% of the 85-year-olds. We also saw around 13% of adults identifying as being neurodivergent, which is new data, around a quarter as Black and racially minoritized, which is roughly the same as the census, and about 0.4% as refugee or asylum seeker status, and 4% having ever lived in care, again, new data, and 0.9% living in temporary or emergency accommodation. One of the aspects of health counts is that it means, because it's done over time, it means we can compare trends. So the arrows that you'll see in the summary report show whether there's been an increase or decrease compared to the previous health count surveys. Obviously, trend data is not available for all the items or indicators, and that's because we've already mentioned we introduced some new questions in this phase, but also because some definitions may have changed over time. But you can see that the health counts data show worsening trends over time compared to previous health count surveys for a fair number of indicators, particularly general health, happiness, anxiety, pain, drug use, community cohesion, community safety. Although, as you can see, we have seen an improvement in reduction of smoking overall. Similarly, health counts also allows the comparison, or it allows us to compare data from other surveys where it's available locally. And if it's not available locally, then you can compare that nationally. Here, again, you can see the health count shows worse rates for the city compared to other local national surveys. And again, you see general health, happiness, anxiety, again, disability, unpaid care, self-harm, suicidal thoughts, vaping, drug use, healthy weight, visiting the dentist, feeling safe at night, and harassment. Although we see some better rates around the amount of time spent in nature and the proportion of people taking actions due to the cost of living. Now, a considerable advantage of the health counts data is that it does allow you to track and identify inequalities over time, showing which population groups, but also which areas of the city are more or less likely to experience that particular indicator in question. So in addition to the city as a whole, we also report on the most and the least deprived areas of the city, each of which represent 20% of the total city. So the table on the right just gives you a sense of some of those indicators. In all 4 surveys, respondents were asked about the perception of their own health, which can be a really useful indicator of an individual's overall health status, but it's also a very strong predictor of their actual health outcomes. As you can see here, only 56% of residents living in the most deprived areas reported it being good or poor health, good or better health. And that was compared to 76% of those in the least deprived areas. And we actually see the absolute inequality gap for this indicator has widened from 15% to 20% in 2024. If you also look at those people living in the most deprived areas, they're also more likely to report higher anxiety scores. So you've got 46 versus 29%. They're more likely to have self-harmed, 12 versus 6. They're more likely to have experienced suicidal thoughts. They're more likely to smoke or vape, and they're more likely to experience gambling-related harms. You can also see that people living in those deprived areas are also more likely not to visit the dentist, are worried about the housing conditions, have a lower sense of belonging to the local community, and are less likely to have someone they know who they can ask for help if they're ill, if they're worried about feeling unsafe at night, and they're more worried about physical violence against them. If you look a little more closely at general health again, so I've already mentioned the 76% for those in the most disadvantaged versus the least disadvantaged. When you look at that by certain population groups, you can also see that there are certain groups less likely to be in good or better health, and that includes those over 75, females, trans and non-binary people, LGBTQ+ adults, disabled adults, autistic people, those who are neurodivergent, those living in temporary or emergency accommodation, those with experience of the care system, and so on. What you also see when you look at geography is that there are people living in particular areas of the city that are also less likely to be in good or better health. And this is Whitehawk, Molescombe, Beverdene, Colin, Stamner, Kemp Town, Central Brighton, and so on. What you start to see when you look at other indicators is then sometimes a familiar picture. So when you look at self-harm, here we ask people whether they had self-harmed in the last 12 months, but not with the intention of killing themselves. 12% of people living in the most deprived areas reported self-harming in the last 12 months, compared to 6% in the least deprived. And again, if you start looking at particular population groups who are more likely to self-harm, you see young people who are aged 18 to 34, so 28% versus 1% for those over 65. People from mixed or multiple ethnic groups, Gypsy, Roma, traveller adults, LGBTQI+ people, disabled adults, neurodivergent adults, those with experience of the care system. So again, we're starting to see some similar patterns here. If you also look at the self-harm in certain terms of the certain areas of the city, we see similar patterns as well. So again, Molescombe and Bevendine, Corley and Stanmer, Kemp Town, and central Brighton. If you then look at the indicators relating to the building blocks of health, so essentially the wider determinants of health, such as employment, housing, income, and so on. In this 2024 version, we included new measures around cost of living and housing condition worries into the survey for the first time. As you can see here on the left, most people in the city report taking at least one action to mitigate against cost of living. Around 21% of adults reporting being worried or fairly worried about their housing conditions, so being damp or cold. And if you look at that by deprivation, that then rises to 27% for those in the most deprived areas of the city, compared to 10% for those living the least deprived. If you skip over to hate crime on the right, we have around 30% of adults being worried about being targeted for hate crime, rising to 67% for trans, non-binary and intersex people. So this was 11% for disabled people, and then nearly a quarter of respondents who are Black or racially minoritized reported being worried about being the target of a hate crime. So hopefully that's just a very quick whistle-stop tour of the Health Council's findings, which just wanted to say, as always, a huge thanks to all those partners who were involved, including the residents of the city. So I'm going to hand back to Louise now, who's going to present the outcomes of the Health and Wellbeing Partnership event that we had at the university back in June. So let me stop sharing, Louise. Okay, there you go.
Okay. That's showing the wrong slide. I'm not sure how that's happened.
Yeah, it's slowing.
I'm so sorry. I'm going to have to really quickly go through them. I did have that set up. Okay, thank you. Apologies for that. Okay, so the University of Brighton hosted a Health and Wellbeing Board partnership event on the 18th of June this year to facilitate multi-organisational conversations. So this half-day event included senior leaders across Brighton Hove City Council, including elected councillors, NHS commissioners and providers, community and voluntary sector leaders and others. So I'm aware and want to thank people here in the room because Chair opened this event, and as a partnership event, many of the people here were involved both in the organisation but also the delivery and facilitation on the day. And we did have very good representation across different sectors. So on the day itself, it included a presentation of Health Council findings, similar to what you just heard from Nigel, and that was followed by facilitated table discussions. We asked a number of things, but one of the key 2 points that we asked was around what might we do differently as a system to tackle these inequalities. So that's inequalities evidenced in the Health Council survey. And then we also asked each group, so that's each table discussion group, to come up with one impactful idea to share. Those impactful ideas are in your paper on page 152. The event was funded by the University of Brighton and NHS England. Okay, so the team is busy at the moment analysing what came out of these discussions. So in terms of what might we do differently as a system to tackle these inequalities, you can see here a list of themes that are also included in the paper. This is really the headings of each of the themes. There's a lot more detail under each of those that we're currently looking at and analysing. So I'm just going to read through the first three. These aren't in any particular order. Okay, so to reframe system culture and leadership, to strengthen collaboration and resource alignment and transform the way we fund services, use data as a tool for action and insight. Okay, I'm just going to mention those there for now, just to give you a sort of flavour of the kinds of themes that came up due to the time, and move on to Chaz now to talk about the next steps.
Thanks, Louise. It's always great to have really good data, but it's what you do with the data that's really key. So in my role as supporting our health and care partnership, I've been working with colleagues just to start to think about how we can use that data to support our work. So the first thing just to sort of stress is and remind us all that actually health inequalities is really key to all of our work. So it's interesting just thinking about the plan for this partnership. We talk about a vision for Brighton and Hove to be a city where people have opportunities to live healthy, happy and fulfilling lives. So this data obviously gives us a real insight into how people feel about their lives and their health. So again, really important data for us as a health and care partnership. As individual partners, the City Council talks about a vision for Brighton Hove to be a city to be proud of, healthy, fair and inclusive city where everyone thrives. And for our NHS partners, there's a statutory duty for NHS bodies to consider and address health inequality. So we really want to stress that this is data that as a partnership and for individual partners can be really used to inform our strategic and our statutory responsibilities, especially on this theme around health inequalities. So then as Health and Wellbeing Board at our meeting a couple of meetings ago, we agreed to share delivery plan objectives for this year. One of those we actually said was to actually action the Health Counts results survey in our shared delivery plan objectives. So actually the different partnership groups that are working underneath this board are already starting to look at that data and develop how we can action that. And one of those is around the development of our new sort of integrated community team. So the great thing about the Health Counts data is we've been able to map it to the three. So we have the 3 neighbourhood partnerships in the city across the east, central and west, and we're able to map that data to those partnerships. A number of those areas of deprivation fit well within each of those 3 partnerships. So those partnerships, those local neighbourhood partnerships, will be able to use that localised data to come up with localised plans around how we can best support the health and care needs of those partners. A really good example of work and those partnerships are already doing some of that work. So a lot of the data points to the east of the city having some particular challenges. So we've got the new community health hub in the city that partners have come together to enable and support people to better access health and care within that element of the city. So good examples already of the work those partnerships are doing that really support us actioning the sort of health counts data at a neighbourhood level. So that's just sort of reflecting on some of the work, and we're working with our ICT partnership groups and with colleagues to then look at that came out of the development session that we had, Louise, to really think about how we start to take that information and to come up with an action plan. And we'll be bringing that action plan back to this board in due course.
Okay, I think that's it. Shall I stop sharing?
Okay, thank you everybody for your contributions. Do we have any questions or comments? Yes, Stephen?
Well, thank you, team. I think it's the Health Counts survey is such a rich source of information, and I'm completely with Chaz in terms of it's what we do with it that really matters. But also thank you to everyone who organised that great event at the University of Brighton and for the presentations there. I think the energy in the room was amazing, and it was great to be part of that. So there's definitely a willingness among partners to definitely contribute to this agenda. I think in terms of trying to make this move forward, then I think actually there is an opportunity to refresh the Health and Wellbeing Board strategy. That was one of the suggestions that's on page 152. And I think that would feel rather just an action plan on health counts, make it part of the overall strategy makes sense. West Sussex Health and Wellbeing Board have just refreshed their strategy and have called it Improving Lives Together in West Sussex. And I think it would be amazing if we could have an Improving Lives Together in Brighton and Hove to really bring this together. Because I do think the delivery vehicle for these improvements is through the integrated community teams that, again, Chaz has just mentioned. So I think we've got the data, we've got the willingness, I think with just a slight refresh around the strategy to make it come together, and then actually delivery through the ICTs, I think we've actually got the perfect opportunity here to genuinely improving lives together in Brighton and Hove.
Thank you. Any more comments or question?
Thank you, Chair. It's probably a question for Nigel, really, about sort of data control. Really, some of the figures are so stark compared to some national comparison points, such as the suicidal thoughts in the last 12 months, 5 times higher than the national figure. I just wonder if there was what were some of the weighting demographics and other factors that were brought into play, and was it possible for one of those to be the frequency with which respondents access their GP surgery? I just wonder if there's any potential for a disproportionate number of people who access their GP services more than average, and therefore they're predisposed to disclosing health and wellbeing issues. It was just something I was wondering, because obviously some of those figures are so much bigger than the national comparison point.
Yeah, good question. I think it's important to acknowledge, though the sample is large and was weighted, it still is nevertheless a convenient sample, and it's important to recognise that. We did weight the data by age, by sex, binary sex weighting, and also deprivation quintile. And that weighting process is really important because for one of the main reasons what you're kind of getting at there is that we did see a greater proportion of older people responding, and that was to be expected when you recruit through GP practices, because generally you tend to see greater use of those services by population. Hence, weighting by age was essential. We were very careful to, when we looked and tested the questions, to ensure that we include as much consultation with members of the public, with community partners, academics, VCSEs, as many sectors you can possibly think of, to get feedback around the questions, to make sure that that they were as valid as they could be. So we're fairly confident that the weighted sample is pretty representative of the population. I think it's because of all the issues that I mentioned earlier in terms of things like GDPR being in, the cost issues, all the challenges in recruiting or generating a large enough sample, actually being able to recruit or promote the survey through GP practices was an incredible opportunity and greatly increased the probability of people actually being able to respond to the survey. So from my perspective, I'm fairly confident as we can be in any kind of survey like this, that that we saw such a good response rate, partly because of the way we promoted the survey and the way it was accessible, but also through the very long and complex development and testing process. So yeah, I hope that answered your question. Sorry, a little bit rambling, but details of more of the specifics about how the data is weighted is available in a technical report, which we can share through the public health team, if that's helpful.
Yeah, thank you, Nigel. I mean, just a layman's question, really. That I was interested in, and I totally took your earlier point about the difference between the wording of like the census questions. Obviously, I'm someone who works with unpaid carers. We were far from happy with how the carer questions were framed in the census. So I can see why the demographics ones had that disparity for sure. But yeah, thank you.
No, pleasure. Just to come back on that, even the questions we asked around caring, as you'll see, showed that there's actually a much greater proportion of people who are unpaid carers in the city than we felt before. And again, how you ask that question can make a very large difference in the way that people respond. But yeah, so thank you for the question. It's a good question.
Thank you. Any more questions or comments? Okay. The recommendation is that the board notes the publication of the health count summary and full report and the update from the Health Counts Health and Wellbeing Board partnership event and supports the next steps. Does the board agree? Okay, the next item on the agenda is Better Care Fund 2024-25 end of the year report. I would like to invite Jess Walker, Program Director, Integrated Service Transformation, to present the report.
Thank you, Chair. There was obviously a report in the papers. I've just got a short slide deck that will just help us take us through the key points from the report. So I'll just share my screen. So the report covers two things. So we had our end of year reporting for 24-25. Within the end of year reporting template that we send to NHS England, we're required to say when we'll be taking the report through and to the health and wellbeing boards. So we're asking you to endorse the end of year report, and I'll take you through the key points of that. And the second element I'm covering is just an update on the 25-26 plan that we submitted in at the beginning of this financial year. So an update on that plan. So just for context, the Better Care Funds is, as I'm sure most of you are aware, it's a long-standing national programme designed to integrate health and social care services, improve health and wellbeing of our local population. The latest BCF policy framework for this year actually links to NHS, the new national NHS reform aims, supporting the shift from sickness to prevention and supporting people to live independently in the shift from hospital to home. It's a pooled budget across the local authority and NHS Sussex. Services are planned and commissioned and delivered at the locally through this Health and Wellbeing Board. Health and Wellbeing Boards are accountable to NHS England and the Department of Health and Social Care for the application of the grant. So in terms of our end of year reporting for 24-25, I can confirm that we were fully compliant with the national conditions of the grant and sections and having the right Section 75 agreement in place to manage the pooled budget. In terms of our financial sort of compliance over the year, I can confirm that we fully spent the grant for 24-25, and we met the minimum contributions to social care and spend the minimum contributions on our hospital and discharge requirements. So confirm that those were met. Then our metric performance for the year, there are 4 metric targets that we have to set targets for and then monitor performance against those metric targets. Sorry, it's not very clear on the screen, so hopefully it's clearer in the reports that you had. So the first one is avoidable admissions, and I can confirm that we met that target. So on the report, where the sort of highlighting is, we've highlighted how Brighton Hove performs against our sort of the Sussex average. Also, really helpfully now that the metric performance we can break down to an ICT level, so we can highlight across the city, across our 3 partnerships. So although we met the target, there's a really interesting statistic in the east of the city where significantly higher for avoidable admissions than we are in the rest of the city. So we just wanted to sort of point that out. Again, I talked about the health hub in the last presentation, where that health hub's within the east of the city, and we think it's one of those initiatives that really helps. So where we want to be able to manage people's conditions in the community and not through the hospital, having that health hub, improving access to community health and care will hopefully help, and targeting at that area of the city will hopefully help us improve performance in that part of the city. So the next metric target is discharge to normal place of residence. So again, I can confirm that we met that target, and there were no particular variances when we look at that at a localised level. Then the third target is falls emissions for falls in people over 65 years of age, and we didn't meet that target. And when we look at the data in a little bit more detail, we can see that there are particular high levels of falls, highest in the west of the city and then in the east of the city, where we have the greatest number of falls. So it is a particular focus of our local work at the moment and across the whole Sussex system. So we talked again about the neighbourhood health plan, and the neighbourhood health plan this year has real focus on people who are frail with complex health needs. So those people are those potentially most likely to fall. One of the actions from that focus is setting up multidisciplinary teams across our ICTs that will then be able to, through those multidisciplinary teams, risk stratify patients in those local areas that are most likely to fit that frailty and complex health needs, and then deliver proactive care interventions to those. So we believe that approach will start to support us in reducing the number of emissions for falls. Also, West being the highest area in the city for falls, I think most of you aware we've been running through the ICT a proactive care pilot around frailty, identifying people who are Rockwood scale 5 to 6. So that moderate frailty level. So, but that early intervention, so before people hit that significant risk high frailty level, and then doing an assessment of their needs and engaging with them in a more proactive way. And again, that was showing really good results. We're continuing with that work, and obviously we're targeting a part of the city where we do have the highest level of falls. So, and again, partners locally, we have a falls plan locally. We're looking at that plan as partners to think about how can we continue to build and develop that to try and reduce the number of falls we're seeing in our for over 65s in our hospital system. Then the final metric is one collected by Adult Social Care, and it measures the number of residential and nursing emissions in the city. So again, it's quite small on the screen, but the data shows that we measure against peer authorities, and our data is a lot higher than those peer authorities for residential admissions. One of the couple of things we're looking at, one is we have some good extra care provision in the city, so which enables people to live in an independent environment, but to get the care and support they need. We're doing a bit of a deeper dive into are the right people accessing that extra care provision, and who could possibly not be going into residential care, but being able to be maintained independently within that extra care provision. We also, as a partnership, looking at the night monitoring service that the BCF actually funds, and considering if that night monitoring service could support people to remain in the community rather than necessarily seeing them admitted to residential care if they've got the right monitoring support overnight, which can be where carers aren't available. So there are two actions that the local authority are looking at now to try and reduce our residential admissions. So that covers the sort of 24-25, our end of year performance. The last thing I said I'd do is a quick update on our current 25-26 plan. So the board approved our 25-26 plan, and we submitted it to NHS England. And last month we got the feedback on the plan. So the plan has been approved, but there was one condition attached to the plan around our sort of metric performance. So it's really important to stress this condition was attached to East and West Sussex as well. So they're looking at us as a system. We're in the bottom quartile for some of our discharge performance. So, and when we submitted our plans, and East and West Sussex is the same, we didn't show an improved performance. We carried on this current pattern of performance. A lot of that was when we submitted the plan, we said this was that actually we hadn't finalised with our NHS providers their final projections for the year. So it's very difficult then to put in the right performance targets when we hadn't been able to finalise that data. That data has been finalised. So the condition of the plan is that we agree through the discharge and assessment group a performance improvement plan, and in the second quarter we then look at revising and agreeing new metric targets, which then support that improvement plan. So that is a condition of them approving our plan for 25-26. So.
Thank you, Charles, for the report. Any questions or comments? Yes, Stephen.
Thank you, Chaz. As always, a very good explanation of what's going on. Obviously disappointed that we only achieved 2 of the 4 targets that we set out for in 24-25. However, what I'm reassured by is the fact that we understand why. And I really think that splitting it by the local ICT groups is seriously very helpful. So I think that actually mitigates, to me, some of the issue that we've got. I think obviously a real focus on discharge in 25-26 is really important. And that's also because in the 10-year health plan, it says very clearly on page 83, we will also reform the Better Care Fund for the financial year 26-27, with reform focusing on those services which are essential to deliver in a fully integrated way, such as discharge, intermediate care, rehabilitation and reablement. So I think the focus on discharge is not going to go away. And actually from a system point of view, this is not just a Brighton and Hove issue, it is a West Sussex, Brighton and Hove and East Sussex issue. So I think coming together on that remains important. So thank you for that. Certainly endorse and appreciate the understanding and let's just keep pressing forward. Thank you.
Thank you, yes.
Thank you. And just of note, Chaz is preparing and has presented a report on behalf of Steve Hook, who directs for adult social care, and myself from the ICB. So this is very much a joint piece of work, and we worked really closely with the Sussex Voluntary Leadership Alliance. So VCSE sector partners are also involved in the review of the BCF plan through the BCF steering group. So there's a whole governance around it. And as Stephen said, we've started to now focus more on deep diving into the data and the drivers for the data, which we perhaps hadn't done in a robust way before. We're also taking through the Brighton and Hove BCF steering group particular deep dive sessions. So we have falls, we have aging well, we have avoidance of admission, we look at emergency attendances, what are the key drivers and how we can in essence review the plans that we currently have to be more effective and impactful. And as Stephen and Chaz mentioned, working at a neighbourhood hyper-local level will enable some of those plans to really come to fruition. Whereas when you work more globally, it's hard for plans to stick. Certainly we're in a financially challenged environment, but at a hyper-local level, communities can take ownership and leadership around some of those plans, like the Standing Tall physical activity and programs. We're looking at how we target those because there are only so many programs in the communities that we can sustain, but how we focus those on areas at greatest risk or where the data is identifying greatest need is how we move forward and start to hopefully scale and sustain some of those plans going forward.
Thank you. Yes, please.
Thank you, Chair. Just a comment, it's a little bit similar to Tanya's one earlier when you were speaking about healthy weights and the efficacy of BMI as a measurement. I guess when it comes to discharge, I understand obviously it's not going away, it's a crucial metric, but taking discharge to normal place of residence as a good example, it's not always as simple as that, as saying a high percentage of discharge to normal place of residence is always a good thing, because there are many factors at play, such as the integrated and holistic package of care that goes in place for the discharged patient. And of course, you're not going to be surprised to hear me talk about the impact on an unpaid carer within the family home. If an inappropriate discharge does take place, then you're more likely to see readmissions, carer breakdown, etc. So it's not always good news when somebody, gets added to that statistic about a discharge to the normal place of residence. So perhaps we need to work together as a partnership to figure out how we can report on some of the mitigations if we're in any way falling short of that stat.
Tom, I think it's a really good point. Obviously, the aim is safe and timely discharge, so having safe and timely in the same sentence. I know that we do get a lot of really helpful feedback around. So especially through some of our health forums, I know one or two of them have really looked at that. So it's how do we take that feedback around that safe discharge element, as well as wanting timely discharge, but recognising the point you're making. So.
Thank you. Any more questions, comments? The recommendation is that the board endorses the end of year performance monitoring report for Better Care Fund Plan 2024-25 following submission to NHS Service in May, and notes the national approval of our Better Care Fund Plan for 2025-26, but that this has associated conditions. Does the board agree? All right. So, thank you very much for your attendance and your contributions and your great work. And I'll hold this meeting close. Thank you.